Thanks for asking me to talk about prescribing at the end of life. End of life care means the last year of someone's life, and the basic principles of good prescribing matter throughout that time, including de-prescribing. So if a medicine is helping or protecting a patient, continue it. If it's no longer helpful or no longer beneficial, then you can stop it quite safely. For example, statins in the last weeks or even months of someone's life. In this session, a lot of what I talk about will be the very last days of someone's life when they have begun to actually die and actively die. But remember that best practice recommends thinking about these symptoms and thinking about the medicines to control these symptoms much earlier. So these are anticipatory medicines that we prescribe in anticipation of when they're needed. And that might be some days before someone dies, but it may even be several weeks or during a hospital admission earlier in their hospital stay if the prognosis looks to be guarded, for example. The vast majority of deaths on the wards in CHFT are from illnesses other than cancer. And the medicines that we recommend reflect the most common symptoms in these patients. And generally in decreasing order, these will be respiratory distress or difficulty with or without upper airway secretions. Secondly, agitation and restlessness, which can be quite significant and extreme and very distressing for the patient, for staff, and importantly for their families. And I'm teaching today, following on from a complaint that a family had about the distress that they felt. So these symptoms have a knock-on effect on others. Pain is frequent. Nausea and vomiting may be less so. But my rule of thumb for all of these is if you see a symptom that is distressing a patient, then give a drug or get the nurses that you're working with to give that patient an appropriate medicine. So if we look at these symptoms individually, so respiratory distress and respiratory difficulty. By this I mean increased effort in breathing, so laboured breathing or abdominal breathing. We've all seen these patients chugging along, persistently raised respiratory rate over 25. And think if you're breathing at that rate persistently, it is very exhausting and very distressing. It's not been infrequently that I have seen recordings on nerve centre of respiratory rates of 38, 40, 48, and medicines not given to relieve that effort. So the best combination is to give an opioid and midazolam subcutaneously together as a stat dose. If the patient is opioid naive, 2.5 milligrams of morphine sulfate if their EGFR is greater than 40, and probably 1.25 milligrams of oxycodone if their EGFR is less than 40. If they're already on regular opioids, the recommended dose would be 5 milligrams of oxycodone. The recommended dose would be 5 milligrams of morphine or 2.5 of oxycodone. The dose for midazolam is 2.5 milligrams, and they work very well together. So it's usually a combination of the both. And you repeat that after about 20 minutes. If the patient hasn't settled, repeat that dose. And what I would say is that if more than 2 doses are needed within a 6-hour time period, you probably need a syringe driver for that patient. It's best not to wait for a full 24 hours to elapse, because if the patient has needed 2 doses, they'll probably need 3, and that distress just becomes more and more embedded. A word about secretions, and I think it's important that we think about who are they actually distressing. When a person is unconscious and dying, saliva will pool at the back of the throat and in the upper airways. And as that patient breathes in and out, there's a noise that they make. Once that saliva is there, it's there. It isn't going to go away. However, if the patient isn't actually distressed, all that's needed probably is explanation to families and reassurance that the patient isn't distressed. A small dose of buscopan, hyoscine butyl bromide, 20 milligrams as the start dose, can be helpful if the patient is distressed or trying to clear secretions. And that can also be added to syringe drivers, which I'll talk about in a few minutes. Agitation and restlessness is a very important symptom to recognise, to prepare for, and to manage. And think about it in two ways. Is this myoclonus? Is that those small muscle jerks that patients develop when they are either in renal failure and uremia is a problem, or is this opioid accumulation, again, perhaps potentially aided by renal failure? Or are they actually thrashing about? Are they very motor restless? Are they up and down and in and out of the bed? Is this what we would call terminal agitation in the last hours or day of someone's life? It's really important that you always remember to check for physical causes and to address those. So is this person in urinary retention? Check. Have they got a palpable bladder? Are they fecally impacted? Are they in pain from a pressure area? Are they feverish? And treat those things accordingly. The general restlessness can be helped by midazolam, 2.5 milligrams to 5 milligrams, again as a subcut dose. Haloperidol is probably preferable if the patient has been a little bit paranoid, maybe had some hallucinations, complaining of seeing things on the wall or pointing at things. And again, dependent on renal function, somewhere between 0.5 and 1.5 milligrams subcut as a stat dose. If the person has Parkinson's disease, then levomepromazine, 12.5 milligrams would be a useful alternative to haloperidol. And again, it's really important to remember, if the symptoms haven't settled within half an hour, repeat that dose. It may take a second dose to take effect. Younger patients, and particularly patients who have a history of alcohol excess, may tolerate higher doses of medicines. So be prepared to review and repeat. And again, if you've needed to give the patient more than 2 doses within a 6-hour period or even less, then they probably do need a syringe driver, and that will then give them a steady state of medicine. So again, don't wait until the day team are there or wait for the end of the weekend. Try and address these symptoms as early as possible. Pain, although less commonly seen in illnesses other than cancer, it is a frequent occurrence and quite common in patients with congestive cardiac failure or COPD or dementia. And both opioid medicines and adjuncts such as anti-inflammatories can be helpful in these patients. Don't be fearful to use opioid medicines, even in patients who've never had them before. We're talking about small doses, and they can be really very effective. Buscopan is also useful, remember, for colicky abdominal pain. You've got to balance up the risks of constipation with it, but for this group of patients, it's probably a very useful medicine. And as with any pain, assess its nature. Use your Socrates acronym. Is it coming from a pressure sore? Is it coming from bone pain? Is it coming from the classical nociceptive pain from cancer or from inflammation or infection, and be prepared to use small but effective doses of opioids. As I say, these patients will probably need a syringe driver, and if a patient has been taking regular opioids, then there's a very helpful conversion chart on the end of life care pages. I don't remember this stuff in my head, and I do it all the time. So it's there and it's available. If it's a bit more complex, it's okay to ring for advice. So ring the hospital palliative care team during the day, and there's always a consultant advice out of hours for you to get a hold of. When you're going to start a syringe driver, you remember this is a 24-hour infusion, so the dose needs to be effective for that 24-hour period. And for mild respiratory distress and for pain or agitation, a starting dose for patients who have not been taking regular opioids of 10 milligrams of morphine, or the equivalent of 5 milligrams of oxycodone. Always remember that oxycodone is twice as potent as morphine sulfate. So effectively, the dose that you prescribe is half what you might be used to when you think about your first off morphine dose. But 5 milligrams over 24 hours of oxycodone and probably 10 milligrams of midazolam will suffice as a starting dose. But remember that regular review and regular reassessment and early action if symptoms recur. And let the nurses that are part of the team, let them know it's okay. You can repeat this medicine. This is the starting dose. Encourage them to use the medicines if they see those symptoms. In COVID-19 patients, which we're seeing still quite a lot of at the moment, we have found that higher doses of midazolam have been needed. And again, some patient groups may tolerate higher doses of medicines, particularly if they've induced their liver enzymes over years. For buscopan, for both the secretions or the management of colic, you need probably at least 60 milligrams in a syringe driver over 24 hours. I've sometimes seen 20 milligrams, but you need at least 60 over 24 hours. And just a reminder again, which opioid do you use? And that will be dependent on primarily on renal function. So normal renal function with an eGFR of more than 40, morphine sulfate is your gold standard opioid. Less than 40, oxycodone, and less than 10, we would recommend alfentanil in a syringe driver with the use of oxycodone PRN. It's very, very short acting and has no role as a PRN medicine, but oxycodone would be appropriate for that. And again, all the information on how to convert from one to another is on the chart. But if in doubt, ring for advice. A lot of these patients, a lot of these decisions to change focus happen at a weekend or out of hours. Ideally, that should be planned for and documented in advance of that time. But sadly, I know that doesn't always happen. And you can be in a difficult position and thinking, well, who do I ring? Please do ring, even if it's late at night or the middle of the night. There is a palliative medicine consultant available 24 hours a day, 7 days a week, 365 days a year. If you get us in the middle of the night, yes, we might be a little bit sleepy at the start, but we'll get the information from you and we'll try and give you as much information as we can based on what you can tell us. So please do ring. As I say, if it's during the day, contact the specialist palliative care team, even if it's just to pick our brains. These are challenging cases, but they can be so satisfying and so rewarding when you can help. And it really does make a difference. Thank you.
And how did they get hold of you, Mary, out of hours?
Best way is probably to get us through switchboard. So ring hospital switchboard and ask to be put through to the palliative medicine consultant on call.
Thank you.